will not respond well to chemotherapy. And so it was almost a palliative or prophylactic ostomy, just knowing how these patients do. It was actually not a good thing, but I think a more favorable histology that she's a carcinosarcoma. So hopefully she'll respond to platinum-based therapy and we can reverse that at some point down the road based on how she responds. But she had a lot of disease left and likely an impending obstruction.
Gabriella, did we anticipate that the sarcoma would involve the bowel, and did we prepare the bowel for the possibility of bowel resection?
We did. I mean, we knew she had a large omental implant. I do not know if there was a bowel prep done. I didn't see that in the notes.
We didn't prep her. I saw her a week and a half before this operation and reviewed her scan from less than 2 weeks before, and this thing had exploded. So we didn't prep her, but there were no ostomy complications. She did end up having an outpatient UTI treated last week, likely from her indwelling catheter, but she's okay. We're gonna get her to chemo.
Just of note, current evidence suggests that mechanical bowel prep alone is not necessary and does not necessarily reduce surgical site infection risk. So you don't always have to bowel prep these patients. However, it can be some institutional practices vary and it can be surgeon preference as well. So some surgeons still perform mechanical bowel prep and give oral antibiotics together when a resection is planned.
All right, well, thank you. Are there any other questions or comments? All right, well, Gabriella, thank you so much for this excellent presentation. And we'll just take a 2-minute break and then we'll get ready for grand rounds. Thank you. All right, so I think we can get started. In just a minute, I'm going to be asking Dr. Patankar to introduce our grand round speaker. But in the meantime, just a word or two about attendance. We'll be taking attendance for department purposes around 8:10 If your name is displayed clearly in the participants list, then you'll get full credit for attendance. If a computer name is displayed or a phone number that we don't recognize, then you can email your attendance to me or Michelle or to Beth. The CME code will be distributed via the email system later on in the hour. And with that, Dr. Patenkar, are you ready to introduce our speaker?
Yes. Good morning. It's my pleasure to welcome you to today's Grand Rounds. We are honored to have a truly distinguished speaker joining us this morning, someone whose career reflects exceptional service, leadership, and advocacy in women's health. Dr. Erin Kaiser is an Army Lieutenant Colonel and currently serves as the Director of Medical Education and Associate Dean of the San Antonio Uniformed Services Health Education Consortium. She earned her undergraduate degrees in evolution and ecology and Spanish from the University of California, Davis, and her medical degree from Albert Einstein College of Medicine in New York. She then completed her OBGYN residency training at the San Antonio Uniformed Services Health Education Consortium. Following residency, Dr. Kaiser practiced as an OBGYN at William Beaumont Army Medical Center in Texas and deployed to Afghanistan, where she was a battalion surgeon with the 4th Infantry Division. Since returning to San Antonio in 2015, she has played a pivotal role in shaping the next generation of physicians. As both Associate Program Director and Program Director of OBGYN residency programs, she has mentored countless residents and medical students. She currently serves as an Associate Professor at the Uniformed Services University of the Health Sciences and has received numerous teaching and leadership honors, including the 2023 Health Equity Advocate Award from Brooke Army Medical Center. Dr. Kaiser's national leadership has been equally impactful. She served as the Young Physician at Large at ACOG's National Executive Board and is currently an oral board examiner for ABOG. Her research and her national presentations underscore her deep commitment to maternal health equity, clinician wellness, and military medical readiness. So today she will be speaking on a topic that bridges her expertise in gynecology and survivorship care, pink problems, gynecologic issues in breast cancer survivors. So please join me in warmly welcoming Dr. Erin Kaiser.
Well, thank you so much for that welcome. I want you to email me that. I'm going to spread that around. That was so beautifully written. Good morning, everyone. Thank you so much for having me. My name is Erin Kaiser. I'm a generalist OBGYN, and I'm going to talk to you about pain problems. Can everyone hear me okay?
Yes, loud and clear.
Okay, great. So first, I do have to let you know I have no financial disclosures. Maybe when I finish my military commitment, I can have financial disclosures. And then I do need to tell you that the views, everything I'm going to talk about today are my opinions, and they are not the opinion of anyone in the military. These are our learning objectives for today. Okay. So cancer treatments are improving, and because of that, we are seeing more and more survivors. There are more than 18 million cancer survivors in the United States right now, and they make up almost 5% of the population, with a projection for 26 million survivors by 2040. And as we know, the most common cancer in women is breast cancer. 317,000 women will be diagnosed with breast cancer this year, making up 30% of all new cancers. And with survival rates in the high 90s for early stage disease, that means lots of breast cancer survivors. And so right now in the US, there are more than 3.8 million breast cancer survivors. I know we see it every week in our GYN pre-op conference, lots of breast cancer survivors. And I'm guessing you see that as well. I can't see your faces, so I'm going to assume you're nodding your heads. With 1 in 8 women being diagnosed with breast cancer, I don't think there's anyone in the audience who hasn't been affected by breast cancer. And in March of 2015, at the age of 34, I was diagnosed with breast cancer. And I found that despite being a board certified OBGYN, I was ill-equipped to deal with the issues that GYN survivor or breast cancer survivor faces. And so as more and more women are surviving breast cancer, I have made this my mission to try and educate everyone on how to best provide care to these patients. So both as the patient and the doctor, I hope to empower you with tools to provide them the best care. So in my PD role, I'd like to do a quick review of the treatment of breast cancer, because although we don't typically treat this, they continue to ask these questions on our CREAG exams and in our board exams. So I think it's important to understand kind of the basics. So in general, treatment usually starts with some kind of surgery, and that can be mastectomy versus lumpectomy, depending on where it's located on the breast and if there's more than one lesion. It typically starts with a sentinel node dissection and only continues to axillary node if the sentinel nodes are positive and or there's evidence of nodal disease prior to surgery. Then plus or minus radiation based on positive margins, and then plus or minus chemotherapy. Nowadays, they are really considering if everyone needs chemotherapy, if it's very early stage disease, and they're doing something called an oncotype, which kind of looks at the things we're used to looking at to predict aggressiveness, lymph vascular space involvement, etc. There's some genetic markers. And so the traditional chemotherapy they use is ACT or adriamycin, cyclophosphamide, and paclitaxel. And sometimes they're even just going taxotere and cyclophosphamide. And remember, cyclophosphamide is ovarian toxic. Adriamycin affects the heart, and Taxol commonly causes like neuropathies in your fingers. And then plus or minus some kind of adjuvant treatment for 5 to 10 years if the receptor status is positive for estrogen receptors. And although breast cancer the treatment is super tailored and differs based on estrogen receptor, HER2, all those things, what we're mostly going to focus on is ER/PR positive cancer, because one, that is the most common, and two, that tends to cause the most GYN side effects, as you can imagine. So the medications commonly used in the management of breast cancer is tamoxifen has classically been used. It's a selective estrogen receptor modulator. And remember, selective estrogen receptor modulators can be agonistic in some tissue and antagonistic in others. So it works as an antagonist in the breast. However, it does act as an agonist in the uterus. So the risks, some of the risks have to do with endometrial polyps, increased risk of uterine cancer. And the other big risk with SERMs are the increased risk of venous thromboembolism. The most common side effect seen with tamoxifen is vasomotor symptoms, so hot flashes. The other group of medications are aromatase inhibitors. I think most of us are familiar with letrozole. We use it a lot in the REI world. And so remember, if you're using this in a premenopausal patient, it can cause ovarian stimulation. So classically, aromatase inhibitors for breast cancer were used in postmenopausal patients, although that has changed. But if it's used in premenopausal women, remember, it does require ovarian suppression in addition to the aromatase inhibitor. The biggest risks with aromatase inhibitors have to do with bone health, and there is some increased cardiovascular risks. The side effects include vasomotor symptoms, arthralgias like bone and muscle pain, and then vulvovaginal discomfort. And the discomfort is not just dyspareunia, but severe discomfort causing like fissures when they wipe after urinating, kind of constant burning pain. So it can be pretty uncomfortable. If you've ever seen a premenopausal breast cancer survivor on ovarian suppression on aromatase inhibitors, they have the most impressive atrophy you've probably ever seen. So breast cancer treatment can have significant effects on all of these things, right? Body image, fertility, menopause. I think if you think about what makes a woman feel like a woman, most people would say their hair, their breast, and both of those things are usually taken away in the treatment of cancer. So body image, appearance can be a major factor, but it can also affect fertility. Obviously, it can change their menopause status, sexual function, osteoporosis, cardiovascular disease, etc. So we're going to kind of try and touch on most of these and how it affects patients. The first topic I'm going to touch on is bilateral salpingo oophorectomy, because I think this kind of sets the stage for their treatment and their status. So I don't know, I feel like we get quite a few consults from breast cancer survivors discussing BSO and their management. I'm guessing you guys do as well. I can't see faces, so I don't know if you're nodding. So the first question is BSO, to remove or not to remove the ovaries. So obviously, if they are BRCA positive, we're going to follow the established guidelines. But what about everyone else? Because that's only going to make up about 10%. So I do want to bring your attention to two trials that kind of changed the management of breast cancer in premenopausal patients. So prior to 2015, if you were premenopausal breast cancer, ER/PR positive, after surgery, chemo, you were placed on tamoxifen. And if you were postmenopausal, you were placed on aromatase inhibitors, because previous studies had already shown that that was superior. So that did beg the question that would aromatase inhibitors be superior in premenopausal patients as well? So that brought the text and the soft trials. And the text and soft trials were phase 3 randomized clinical trials in premenopausal women with estrogen receptor early breast cancer. The two trials were done concurrently and designed to be complementary with the hopes of bringing the results to patients sooner. Ovarian suppression had been used for decades as a breast cancer treatment, and whether it added benefit with these additional medications was still uncertain. So that's really what it hoped to show. So the text trial compared tamoxifen, which was tamoxifen with ovarian suppression, plus aromatase inhibitor with ovarian suppression. And then the soft trial compared those same two arms with tamoxifen alone, which was kind of considered the standard of care at the time. Ovarian suppression could be done with some kind of GnRH agonist-antagonist suppression, BSO, or if they'd had previous radiation to their ovaries. So this is kind of looking at how it went, how it was stratified and how it was broken down. And then if you combine all the results together, you can see that in all groups broken down, the aromatase inhibitor, they used exemestane in this study. The aromatase inhibitor with ovarian suppression was superior, kind of in all groups, for overall survival and disease-free survival. So in 2014, it was published that in premenopausal women with hormone receptor positive early breast cancer, treatment with aromatase inhibitor with ovarian suppression as compared to tamoxifen alone or tamoxifen with ovarian suppression did reduce recurrence. And so a lot of people moved directly to that treatment for premenopausal women. And since those studies were published in 2015, there's been several follow-on studies that looked at the survivors, and it continues to stand the test of time. In the meta-analysis published in 2022 of the subsequent studies, aromatase inhibitor with ovarian suppression continues to show improved survival and decreased cancer occurrence. So what does this mean for us as gynecologists, and why am I going on about these studies that you're like, I don't care about? So this is the side effect profile from the text and soft trials for aromatase inhibitor with ovarian suppression. And I kind of purposely put it up here unreadable just to show you like how vast it is. And all of a sudden, when I'm the patient now, I'm not looking at the Kaplan-Meier survival curves. I'm looking at how am I going to feel, right? And so I broke it down for you. So these are the side effects of the aromatase inhibitor group with ovarian suppression. And you can see hot flashes, 92%, depression, 87%, vaginal dryness, 52%, decreased libido, 45%. And I would argue that hot flashes, vaginal dryness, decreased libido, dyspareunia, these are all things these patients are coming to see you for. So I think it's important that we're recognizing why we're seeing all these side effects. And I do want to take a moment that this was published, you know, it's been about 10 years now that we've switched a lot of care to aromatase inhibitors. And I do want to remind us of the Nurses' Health Study. I think most of you are familiar with the Nurses' Health Study. It's kind of one of those landmark papers that it was initially started like in 1976, looking at the side effects of contraception. Why nurses? Because they thought they'd be more likely to return questionnaires, but it's like that long prospective study funded by the NIH. But in 2013, that study published data about timing of BSO. And I don't know how you all practice there, but I feel like when I was a resident, it was if you were 45 and older and getting a hysterectomy, we took out your ovaries because we were saving lives by decreasing ovarian cancer. And if you were 45 and under, we left them. And then when this study came out, it really changed that to kind of that look at like 60, 65, because what we found was, although yes, that risk of ovarian cancer is decreased if you take out the ovaries, it is completely overshadowed by that increased risk of cardiovascular disease and really all-cause mortality. So I think us as gynecologists, even in the evolution of my I'm going to say short career, my short career, we know that premature removal of ovaries is not completely without risk. And keep in mind, we're now talking about a patient population that is not a candidate for hormone replacement therapy. So I just think we need to be cautious when we jump to taking out ovaries. And then this is a study in Gynonc, who I'm sure all the Gynocs are familiar with. This was looking at BRCA patients who underwent risk-reducing BSO. So these are not cancer survivors. They didn't get chemo. They didn't have, all the other side effects you could put with cancer. And just removing their ovaries, it had a prevalence of sexual dysfunction of 74%. So my point being, remember, the ovaries do more than just produce estrogen. So what are my thoughts on this? So it kind of leaves us in this little bit of a conundrum. In general, I think if you're under 35, I think there's a place to leave your ovaries in place and temporarily medically suppress them for 5 to 10 years. I say that window because that is changing, and now they're oftentimes offering adjuvant therapy for up to 10 years, because it's possible, especially if they've been suppressed, that when they stop their adjuvant therapy, that they could have return of ovarian function and hopefully an improved quality of life. If they're over 40, especially if they've received chemotherapy that's ovarian toxic, I probably don't see the benefit. What I found is I'll do this counseling with patients and they'll be like, yeah, I'm going to leave my ovaries. And then they get tired of having to come in and get the shots regularly to do the ovarian suppression. And our hemonc department is a stickler on using what was in the study. And it's like the monthly goserelin injections into your abdomen. And so they really don't like that. They're just like, I just want them out because I want to not have to come in here every month. So it is a discussion, and I do recognize that there's a 5-year gap where I don't have a recommendation. So that's really where like shared decision-making comes in. Okay, before I move to the next topic, are there any questions on BSO? And maybe Dr. Ebert, you could tell me if I'm missing any.
No questions.
Okay. Okay, I'm going to move on to sexual health. So I do want to bring this to your attention. So this was what do we call these, clinical expert series in the Green Journal that talked about sexual health in women affected by cancer. And she says that despite the fact that no specialty is better qualified to render care for this consequence of cancer treatments, many OBGYNs feel uncomfortable or ill-equipped to address sexual pain in women affected by cancer. And this is definitely what I've seen in my experience in this job, that patients go to their hemoncs and they complain of sexual dysfunction, and they're like, I'm a hemonc. I don't even want to say the word vagina, right? And then they send them to their OBGYN, and their OBGYNs are like, I don't know, you got to talk to your hemonc. I don't know what's safe. And I feel like these patients get kind of left by the wayside. I literally had a young patient. It was right after I was diagnosed. She was my age, and she's like, yeah, they told me there's nothing I can do. And if I never have sex again, it's fine because it's so painful. And she was like 35. And I was like, what? And I think there's a lot of data that shows that women's sexual health is directly tied to their overall sexual function, is important to female cancer patients. And in chronic illnesses, sexual health is a major determinant of how women rate their overall quality of life, and is shown to be a reliable predictor of emotional well-being. And I think if we think of all the cancers that affect women's sexual organs, breast, uterus, ovary, cervix, vagina, vulva, I think there is this like lack of discussion about sexual health. And I think part of it is probably women themselves are like, I survived cancer and now I want to be greedy and say I want to have sex too. Like, I can't bring that up. They're going to think I'm such a jerk. Whereas I can't imagine there is like at the first appointment of like prostate cancer or any other cancer for men where it's not discussed at the very first appointment. So I think we need to do better about addressing kind of sexual health for women and bringing up the topic so that they don't feel shame in addressing it. So this is just to lighten the mood. Okay, so sexual pain and dyspareunia does affect the majority of cancer survivors. So what can we do about it? And I hope after leaving this, you guys feel empowered that you have all the tools. So the first thing is non-hormonal treatment, which there's really limited options, but vaginal lubrication and vaginal moisturizers. I think everyone is familiar with vaginal lubrication, including patients, but I think vaginal moisturizers is something that patients are maybe have not heard of. So I usually tell patients that, and I even tell them to do this as soon as they start treatment, just because I don't want them to completely ignore their vagina and their sexual health. So I tell them, just like at night, you probably go to your room and you have like a face routine where you wash your face and you moisturize your face. Well, every night I want you to moisturize your vagina as well. And so there's lots of options. They can get these on Amazon. You can get it at any drugstore locally. I don't have any preference. It's usually, some are very expensive and some are less expensive. So it's whatever they can afford. Coconut oil is another great option to use as a vaginal moisturizer. You can even get like some of the really expensive ones that you can purchase, I think, are coconut oil based, and they come as like suppositories, which tend to be less messy. And you can even get this little kit from Amazon. We can like make your own coconut oil suppositories, but you can just use coconut oil as is as well. So what about vaginal estrogen? I am happy to say that when I started giving this talk back in like 2016, we had literally no data. It was like clinical expert opinion. So I see a question. So I will pause. Go ahead, Josh. Josh
Perhaps-
raised his hand, but maybe he
Yeah,
put it.
perhaps it was an error because
Okay.
he pulled it down.
Okay. Okay. So I am, when I first started doing this, it was all like, we think it's safe and I don't know, but I'm happy to say that now there's lots of data, which I'm going to show you, because I still feel patients are told they can't take vaginal estrogen. So hopefully afterwards, you guys feel convinced that you can safely prescribe vaginal estrogen to these patients. So initially ACOG had a committee opinion that said, if they're on tamoxifen, you can use vaginal estrogen, but if they're on aromatase inhibitors, you shouldn't. You should take a break. But then they updated that in 2021, which says, yes, you can use vaginal estrogen, whether you're taking tamoxifen or aromatase inhibitor, but they do say it should be a shared decision-making between the patient, the gynecologist, and the oncologist. So this is the only randomized controlled trial I'm actually aware of. It was published in JAMA Oncology, and it compared, it was breast cancer survivors on aromatase inhibitors, and it compared to vaginal testosterone cream to the estradiol vaginal ring or E-string. And it was more of like a safety kind of looking at it, but it did show improvement, estrogen more so than the testosterone in terms of like elasticity, dryness, etc. And then they looked at estradiol levels, and besides some like spurious baseline, they really didn't see an increase in estradiol levels. So overall, they concluded that it was likely safe. Since then, there have been additional studies that look at there have been several cohort studies. This one was published in 2022, it was 117 patients. And actually it was 117 patients who took systemic hormone therapy and 1,200 who took topical. And really they showed no difference in recurrence or mortality. This next one was a claims-based analysis. So they just looked at claims of if you had like ICD-10 codes of like breast cancer and then claimed of getting vaginal estrogen, and they did not find an increased risk of breast cancer occurs within 5 years in women with a personal history of breast cancer who are using vaginal estrogen for genitourinary syndrome of menopause. And this is just looking, this is all breast cancer survivors, and this is an ER positive breast cancer survivors. It was actually protective, which I know you can't really say from this cohort, but and in this was a large cohort study, and a decrease in mortality was seen with vaginal estrogen use, further supporting its use in breast cancer survivors. And most recently, this just came out in AJOG this past month. It was a meta-analysis that was looking at all the studies that have come out since then. A systematic review looking at recurrence risk and mortality risk, and you see breast cancer recurrence, it was, I don't want to say protected, but it was no increased risk, and same for overall mortality. And so this gives us cautious reassurance against about the safety of vaginal estrogen in breast cancer survivors. So I now can say with confidence that I feel it is safe for ER positive breast cancer survivors, whether they're on tamoxifen or aromatase inhibitors, to use vaginal estrogen. I think vaginal estrogen has the most data supporting its use, so that is what I use as my first line. I think there are some small studies that show that Vagifem tablet, which is the estradiol tablet, or the E-string, the estradiol vaginal ring, has the lowest systemic absorption. So that's usually my first line, but I think any topical option is okay. And personally, I don't ask permission from the hemoncs. I notify them that after shared decision-making, this was affecting their quality of life, and we've decided to start this. And I let them know. So that is my practice, but I will let you decide how you want to approach that. Some additional treatments to consider, because you've probably heard of them, and I see a bunch of hands go up. So
You want to answer questions now?
well, if they have a specific question about vaginal estrogen, I'm happy to, or if you
Dr.
want to wait to the
Siegel?
end. But
Yeah,
I see
actually, it was
Shirley.
it was a question before about hyaluronic acid and on vaginal health.
Yeah, go ahead.
I'm on. Can you hear me?
Yes, we hear you, Josh, loud and clear. Go ahead.
Do you use hyaluronic acid as a vaginal moisturizer?
Yeah, so
Ever?
hyaluronic acid is a base, I think, in a lot of the vaginal moisturizers. So I just kind of
Okay.
lump that in with the vaginal moisturizers, but they tend to be like hyaluronic acid based or coconut oil based. It depends on how like the thickness. But yeah, I think that's what's in a lot of those vaginal moisturizers.
And when you say that, I have the same problem, by the way, with all my patients. But what about maybe you're going to talk about it, intrarosa
Yeah, that's next.
okay.
Yeah, that's next.
Dr.
Sure.
Saluki?
Hi, yes. When you use the estrogen cream, do you ever modify it? Let's do 0.5 gram. Let's skip the dose, like loading dose and all of that. Like normally what I do is like 0.5 gram estrogen cream twice a day, like twice weekly for those patients with that kind of history.
I don't. I mean, I also tell them, especially the ones on aromatase inhibitors, to take some of the estrogen cream and put it like on the vulva and the labia, just because that's when they oftentimes have a lot of like issues after like wiping and stuff. So I don't tailor it. I personally really like the E-string. Like I think they get really good relief just because it's like constant daily instead of like twice a week. But so I don't, but I can see your point. Or if the patient's anxious or nervous, you could say that.
Dr. Phillips?
Hi, I just have a question. I think over the past couple years, there were a couple articles that came out saying that in women on aromatase inhibitors, there was an increased risk of recurrence, but not an increased risk of death. Can you address that?
I am not aware of those studies, but I would like to see them.
Okay.
So there are some additional treatments, as he mentioned, that I want to, just so you're tracking. So vaginal DHEA, dihydro, I can't remember, but it's the one that the androgen, the adrenal gland makes. So it's interesting. The initial studies that looked at vaginal DHEA actually included breast cancer survivors. They looked at over 400 postmenopausal women with a history of breast or GYN cancers. It was compounded into a moisturizer versus placebo, and they did see a significant improvement in their symptoms after 12 weeks. And there was no evidence of systemic estrogen activity. However, in the study that the prosterone, which is the what do you call them? The suppositories, those ones did not include breast cancer survivors. And this is the one that was used that went for FDA approval. And this is one where they like biopsied the vagina before and after. So this one, breast cancer patients were excluded, unfortunately. So when it went for FDA approval and got FDA approved, because they were not included in that study, it does have a package insert that says estrogen is a metabolite of prosterone. Use of exogenous estrogen is contraindicated in women with a known or suspected history of breast cancer. Intrarosa has not been studied in women with history of breast cancer. So it's not a black box warning, but it's on the package insert. Since then, there has been a study looking at use of DHEA in breast cancer survivors of patients on aromatase inhibitors, and it did show improvement, and it said it was effective option and safe for these patients. So I think it's reasonable to use DHEA in breast cancer survivors. Another medication that's FDA approved for vulvovaginal atrophy, the old term GUSM, is ospemifene. Ospemifene is a SERM like tamoxifen, except it has unique agonistic effects in the vagina. So it is FDA approved for, like I said, for atrophy. It is a daily oral pill. So sometimes when you have like menopausal patients with GUSM who have like rheumatoid arthritis or have issues inserting anything vaginally, this can be an option. it does beg the question, is there a perfect SERM out there? Could it replace tamoxifen? It does seem to have a weaker agonistic effects in the uterus. It is helpful in the bone, more like raloxifene, and it is helpful it is an antagonist in the breast. Unfortunately, in humans, it did not show to be as strong as tamoxifen. So I don't think it can replace tamoxifen, unfortunately, and it cannot be used concurrently with tamoxifen or aromatase inhibitors. At one point, they actually did a study where they put patients on tamoxifen and aromatase inhibitors, and the patients did worse. So I don't think it's reasonable to do it concurrently. But if a patient has completed their adjuvant therapy, I don't think it's an unreasonable option because it is an antagonist at the breast. But like other SERMs, it does increase the risk of VTE. So you just have to make sure they have no contraindications to taking that. And then the last thing is laser therapy. So I feel like if you've ever been to a national ACOG meeting in the last 10 years, they always have there's 10 more booths that pop up. I think the original one was the Mona Lisa, but I feel like they're always popping up new booths or new products. So the idea of laser therapy has actually been around for a long time in the field of plastic surgery. The idea is that the laser pokes tiny holes into the tissue of the vaginal lining in this instance, but if you're doing scar revisions, and this is supposed to result in new blood flow and healthy tissue growth. So the idea has been around in plastic surgery for a while, but the idea for vaginal health is relatively new. So vaginal biopsies have been done that show the vaginal wall grows thicker and stronger and more elastic with new blood vessels. So there's been multiple, put them all down here, small prospective studies that do show some benefit, that it is probably beneficial for the treatment of genitourinary syndrome and menopause. It's probably effective and safe, but however, most of the data only goes up about 1 year. So we only really have data out to 1 year. There doesn't appear to be any harm seen. However, again, most of the data only goes out 1 year. There's been very few randomized controlled trials. I'm going to show you one that compares to estrogen. But unfortunately, it's expensive. It's been targeted as cosmetic, and so no insurance companies really cover it for any indication of GUSM, and so it's quite expensive. It can be $5,000 for the initial treatment, and then $1,000 for the touch-ups. So it's really quite cost prohibitive for a lot of our patients. This is kind of a systematic review, and again, it appears to be effective, but difficult to assess long-term because most of the studies are they look out 12 weeks. This is the one random double-blind placebo-controlled trial where they did a crossover of laser, estrogen, and then both. Laser and estrogen together were actually the best, and it did show improvement. But again, we really don't have long-term data. And every time I talk about this at ACM, I'm like, if any of you have data 5-10 years, publish it, please. There's one study actually looking at breast cancer survivors because ideally this is a great option for breast cancer survivors because it's a non-hormonal option. And it does show to improve using the female sexual dysfunction scores. It does show to improve a lot of the issues in breast cancer survivors. I do want to say that the ACOG clinical consensus says this about laser therapy. This is what ACOG's opinion. They used to have a big cautionary thing, an ACOG statement that said, be cautious, but in this, they say consistent training and certification for its use are lacking, and there's concerns about the long-term scarring. And it does make sense, I think, in my head when it's if I constantly am remodeling it year after year, because you're supposed to do annual touch-ups, I can see well, what does that look like in 5 years? What does that look like in 10 years? And I'm sure somebody has the data, but I haven't seen it published. It's not FDA approved for this use. It's costly and not covered by insurance, which makes it inaccessible to many individuals. And there's more research is needed before they can recommend this as an indication. I will say anecdotally that my breast cancer patients who were able to get this done, they love it. I had patients who were literally, they would wake up 10 times at night to pee because of the GUSM urgency, nocturia. They could not have sex. They would literally get fissures on their vulva after peeing, and they said it was life-changing. So for what it's worth, it's an option. It's out there. The most consistent predictor of satisfying sexual experiences in women with breast cancer, normally I get a vote from the audience, but since we're virtual, so it's the quality of their relationships. So it's so important to to make sure you're bringing their partner into a lot of these discussions so that they're aware that there are consequences to the sexual health and the management of their breast cancer. And then if you don't use it, you'll lose it. I think all of us as gynecologists have seen patients who have like been menopausal for a long time and never used estrogen, never did anything, and then they like want to have sex and their introitus is, super tiny. So if you have patients who are not in a relationship right now but want to be sexually active, I think there is a place for continuing to use vaginal estrogen and even using, oh my God, what do they call it? In front of the vagina to keep it open. Oh my God, someone help me here. Dilators. Thank you. Using dilators to continue to stretch the vaginal tissue with the use of estrogen. And so sometimes this is where you can bring the partner in. You can say, so you need to have sex once a week. So you continue to stretch the vaginal tissue. And then they can be all excited that they have a job. So kind of my summary for treatment of sexual dysfunction is I tell all patients to start using vaginal moisturizers right away. I think there's no harm to it, and it kind of keeps them paying attention to their vagina. And then if continued issues, I use vaginal estrogen as a first line. I think there's plenty of data now to support its use. I do talk about laser treatment, but it's not the most cost effective if they can afford it or if they have accessibility to it. And then DHEA, I think there's data to support its safety. And then if they've completed their adjuvant therapy, continue considering aspamifene. This is from that clinical consensus, which talks about lubricants, moisturizers, vitamin D and E, vaginal suppositories, lidocaine, and then the different forms of hormonal therapy. All right, we're going to move on to hot flashes. Any questions about the sexual dysfunction piece? Okay, so hot flashes. So I do want to say, as my ABOG hat, first line therapy for hot flashes should be hormone therapy if you don't have any contraindications. But in my experience, the number one contraindication I see is history of breast cancer. So that's where we need to think about non-hormonal options. So Effexor has long been used. It's been shown to have some improvement. Gabapentin can be used. I like gabapentin when I have patients who complain a lot about nighttime hot flashes. Some patients will say, during the day I only get a few, it's manageable, but it really affects my sleep at night. I wake up 10 times at night, sweating. Gabapentin, even going up to like 900 milligrams at night, can really help them sleep better. And then low-dose paroxetine or Paxil. Again, this was the only one that's technically FDA approved of those three for this indication. Of note, it is the 7.5 milligram salt, which I do find a little bit harder to get on formulary sometimes, but that's what's been shown to improve. And then I would just caution you not to use the higher dose because the number one side effect of SSRIs is sexual dysfunction. And then if you have a patient on tamoxifen, there is a contraindication to taking the SSRIs while you're taking tamoxifen because of the cytochrome P450 metabolism. So if you have a patient on tamoxifen, that's when you really need to think about the Effexor or gabapentin preferred. However, we're getting to the new FDA approved one, which really is probably be the first line. Oxybutynin, I think you're all familiar with from Urogyne, which is an anticholinergic or an antimuscarinic for urinary urge incontinence. It actually has been shown to improve vasomotor symptoms. So it can be an option, especially if they're also having some like urge incontinence issues. However, warning in older patients. But the future, the new one, fezolinetant. Are any of you guys using that yet? The new NK3 receptor antagonists?
Yes.
Okay, great. I love that. Okay, so this is the first non-hormonal drug to treat vasomotor symptoms. And so it was FDA approved in May of 2023. So I went to that ACOG meeting in May of 2023, and there was like a neuroscientist who like explained it. So I'm not going to be able to do that as well as she did. But what I heard was as the ovary stops producing estrogen and you have this like hypertrophy in the brain of like the FSH and all those other receptors, it also causes hypertrophy of the KNDy neurons, which is the thermoregulatory center of the brain. So this targets that, and that's what is thought to cause the vasomotor symptoms is the hypertrophy of those receptors. So this targets those receptors. So the Skylight was the first studies that came out looking at Skylight 1, looking at the benefits. And these were 12-week trials that did a crossover. So you'll see that like the 12 weeks, the placebo, can you see my mouse if I do this? The placebo up here is like they don't have improvement. And then when they cross over, they do. So the first studies were just kind of looking at dosages. And so they went with the 45 milligrams because that showed improvement in both frequency and severity of hot flashes. This was the Skylight 2, which again showed improvement, pretty dramatic improvement of the vasomotor symptoms. So the big side effect or the warning that came out with fezolinetant was liver safety. So in 500 patients, there were 6 patients who, upon starting it, had more than 3 times elevation of their LFTs. So there is that warning that you need to get baseline LFTs and repeat them like every 3 months for the first year. I will say in the study, it was seen immediately. So I feel like really, in all honesty, if the first set of LFTs at 3 months is fine, you're probably fine, but they recommend continuing it for the first year. So this was a systematic review, kind of looking at the different treatments of hormone therapy, comparing the non-hormonal forms to the hormonal, and really, I don't know if you've ever looked at the studies with like Effexor and gabapentin. I mean, they're barely better than placebo. Fezolinetant actually was almost as beneficial as a hormone therapy regimen and superior to all the other non-hormonal options. So I do think this should be really our first line if they can't take hormone therapy for whatever reason. And in my experience, patients do really well on this. They really have improvement of their vasomotor symptoms. So I'm curious if the ones using it also find that. In my institution, to get approval, it is kind of, you have to get like you can't just prescribe it for everyone. So in my experience, if you can't take hormone therapy and you have to say what the contraindication is, and then you can't take Paxil or you fail Paxil, then we can get fezolinetant. So for me, if I have any breast cancer survivor on tamoxifen, I can get it pretty straight away. If they're not on tamoxifen, I usually have to say, just try the paroxetine for 3 months. And then if it doesn't help, then we'll put you on the other medication. So that's what I've had success doing. So kind of in general, lifestyle modifications, switch from hot coffee to cold coffee, red wine to white wine. Whatever you can do whatever you find your triggers to be, try and cut down on those. I think fezolinetant should probably be our first line because it has much larger impact on patients than some of the other non-hormonal options. These are the other non-hormonal options that the Menopause Society puts out. And this is kind of my summary, which I think is sometimes helpful. FDA approved, so the only FDA approved non-hormonal options are going to be your paroxetine. Again, contraindicated if they're on tamoxifen, fezolinetant, you'd have to follow liver enzymes, and then the other non-FDA approved options. And then I do want to bring your attention to elinzanetant. So this is the new one. It's not FDA approved yet. Look for OASIS trials. That's what their little ones are called. This is an NK. So the fezolinetant is an NK3 receptor antagonist. This is an NK1 and 3. So it appears to be equally effective. So far, the data do not show the effects on the liver enzymes, but more to come. So I don't know if the FDA will say they don't have to monitor liver enzymes or not, or they may just say because it's the same class, you still have to. But I do want to say for fezolinetant, breast cancer survivors were not in the studies. So whenever you go to the reps, they're always like, hey, I do need to tell you, breast cancer survivors were not studied. I don't think it's a contraindication, but just an awareness. OASIS 4, which is ongoing, is breast cancer survivors taking elinzanetant. So I'm very excited and curious to see what comes out of that. So I think that's going to be hopefully the better one. All right. Questions about vasomotor symptoms? Okay. So contraception, I just want to point out the USMEC currently only breaks it down into current breast cancer and then past or no evidence of disease for 5 years, which I don't think is the most helpful breakdown. I think if you have hormone receptor negative cancer, there's probably more of a place for contraception, especially in these young patients who don't want to get pregnant, but maybe don't have a lot of other options, or they also have heavy menstrual bleeding. So just kind of food for thought. And then fertility. you could do a whole talk on oncofertility, and I'm not going to do that, but I do want to bring your attention to the positive trial. So for a long time, there were previous retrospective studies that were somewhat reassuring for saying, sure, it's probably safe if you get pregnant after breast cancer. But there was always that like bias that, well, only the healthy moms probably were able to get pregnant. So that has like an inherent bias. So this study was the positive trial. And the idea was it was a designed to address the safety of a temporary break in endocrine therapy in young women with hormone receptor positive breast cancer who wanted to become pregnant. It enrolled 518 women who were 42 years or younger, who had stage 1, 2, or 3 disease. They had completed anywhere from 1.5 to 3 years of endocrine adjuvant therapy, and they wanted to become pregnant. They did require a 3-month washout period after stopping the endocrine therapy. And then the plan to follow to complete the last couple of years after they completed breastfeeding. The primary endpoint was looking at the number of like breast cancer events, recurrence, etc. And then they followed an external control cohort of premenopausal women who had the same kind of disease but did not wish to become pregnant. So obviously you can't do like a randomized control trial, placebo, like in someone with pregnancy. And really what they found was really there was no difference in distant recurrence, conjugal breast disease, and basis disease in the two groups. 74% were successful in getting pregnant. 83% of those had a live birth. Of note, 43% did require some kind of like REI services. The rate of breast cancer events were similar. There was no statistical difference. And the best part was that 85% of people after having a child finishing breastfeeding resumed their endocrine therapy. And so this trial really supports the safety of stopping before that 5-year mark and pursuing pregnancy if that's their desires. And what is really nice is that a lot of patients were just non-compliant because they wanted to get pregnant. And so I think this supports saying, I would rather you pause, get pregnant, and then go back on it to complete your adjuvant therapy regimen than just like us ignoring their wishes and then them kind of going rogue, which is probably more harmful in the long run. So again, subsequent pregnancy does not appear to compromise survival. They usually recommend waiting at least 2 years, although in this study, they did stop, some stopped as early as 18 months. You do need to wait 3 months after stopping tamoxifen and 7 months if they are taking Herceptin. And then I do just want to stomp my foot that make sure we're offering fertility, at least counseling or fertility preservation for all of these patients. It appears in the studies that a lot of needs were unmet, that people felt like they weren't really informed of what the consequences were on their fertility, and they really wasn't addressed prior to undergoing treatment. So kind of in summary, to wrap this all up, what is our role as gynecologists in the care of these patients? So I do want to point out that most early stage disease, the surveillance is really like every 3 month breast exams by like their surgeon or hemonc. They really don't do a lot of radiologic imaging or follow-up in these. There's no like tumor markers they're following. There's no radiologic imaging. So it can cause a lot of anxiety and fear of recurrence. So depression does seem to be higher amongst younger patients, anyone with a history of mental health disorders or low socioeconomic status. Obviously, relationship issues play into that, poor self-image, and the decreased libido. So treatments can be mindfulness, psychology, etc. Patients on tamoxifen, annual GYN exams are recommended just to ask the question about any abnormal uterine bleeding. Pap smear screening doesn't change. When I was a resident, we were biopsying all these people, anyone on tamoxifen, which was sad. But so now you don't need to biopsy all these people. The only time you would biopsy is if they do have any abnormal uterine bleeding or postmenopausal bleeding. I would caution you, if someone has bleeding, I wouldn't even really get the ultrasound. The ultrasound's going to just look cystic and terrible. So I would just go immediately to the endometrial sampling. Bone health, a lot of these patients are going to be at risk of osteoporosis due to the aromatase inhibitor use, early menopause, chemotherapy, etc. So usually they're getting DEXA scans every 2 years. There is some data that bisphosphonates decrease the risk of cancer recurrence. So you may see some patients getting that as part of their hemonc therapy. but make sure we're talking to them about lifestyle modifications for good bone health. So my key takeaways: routine pap smear screening. Do ask them about their sexual health. As I said earlier, I think there's a lot of shame with women about asking about wanting to have sex. And so make sure you're addressing that. Ask about hot flashes, assure they're getting their bone screening, screened for depression and anxiety. A great nonprofit resource is Living Beyond Breast Cancer. They have patient-facing pamphlets about fertility after cancer treatment, sexual health, all the things that we talked about. They have great patient-facing material. And that's it. I'm happy to take any questions.
Dr. Kaiser, thank you so much. That was such a great talk. There's a question in the chat. How long can Veoza be used for?
Veoza, that's the phenylazine, yeah. That's a great question. I don't know that there's a time to stop it. I don't know that they've like looked at long term. I think most of the studies only went out like 6 months. So I will ask that the next time I talk to those reps. Yeah, I don't know. I mean, I would imagine we would do like we do with hormone therapy, is like we could do a trial and see if they're still symptomatic. But yeah, I don't know if there is like a no more than. That's a great question.
I see that Dr. Levine has his hand up.
Yes, good morning, and thank you so much for that outstanding presentation. I'm going to be sure to share the recording with my colleagues. As a family physician, I see a lot of premenopausal and postmenopausal patients, survivors of breast cancer, and it really is disappointing how many of these patients don't get asked about sexual dysfunction proactively or offered vaginal estrogen or progesterone. So thank you so much for sharing that. My question is, any studies looking at beta-doxyphene conjugated estrogen or Duavie? I know in their studies they show less breast density, and there was some promise of either maybe preventing breast cancer or maybe being able to be used, but of course they're not doing those studies. But I didn't know if there's been any non-pharma studies looking at that. And also my second question was anything related to the levonorgestrel IUDs. I know how it's still in the new USMEC, it's still listed as 3 and 4, but anything looking at promise for using that in patients who need contraception or cycle control?
Yeah, those are all great questions. I'm not aware of official studies, but I do know I have some Canadian OB/GYN friends who from like the Menopause Society, and I think they are much more liberal with their use of hormone therapy. And they even will do, I've used Duave for like DCIS patients. I mean, I think in the United States, we way overtreat DCIS, which is like a pre-cancer, it's not even a cancer. And so in patients who really want hormone therapy, but like had DCIS, I think bazadoxifene, or I think Duave, the bazadoxifene, is like a great option. Where I feel at least a little bit better about giving them estrogen with the SERM and thinking that it's not going to cause more breast cancer. I've not seen it studied in actual breast cancer patients, but I agree. I think we are so quick to withhold hormone therapy, and if patients are like really struggling. So I've used it in DCIS patients, but I'm not familiar with like any studies studying breast cancer patients. I agree the Mirena is a great option for young patients who want future fertility, especially if they have like heavy menstrual bleeding. There was one study that actually showed an increased risk in like breast cancer, which doesn't make any sense to me. But I mean, I usually say I kind of incorporated it into that USMEC as I think there should be a separate categories. If you have ERP or negative cancer, I don't really think we should be withholding any hormone, any birth control. I think if you've had ERP positive cancer and you're 5 years, and I think Mirena is a great option if they need something, because what else are we giving them, right? If they have heavy menstrual bleeding, we're giving them
Exactly.
There's not a lot of other options. So I think that's where like the shared decision making, and that's probably the safest option.
Thank you so much.
I see that Dr. Siegel has his hand up.
Yeah, hi, great talk. Maybe you can address, do you deal with the BRCA patients who have prophylactic oophorectomies and salpingectomies any differently? I can tell you what I do. But I was wondering if you have any, can you discuss those patients?
Yeah, so I mean, the NCCN guidelines do say we should be giving all of those BRCA patients hormone therapy. I mean, now I guess we're talking about, do they have cancer or not? If they've never had breast cancer, then obviously they should be getting hormone therapy. And actually, they should be on OCPs before they have their prophylactic BSO. So I think there's clear guidelines that those patients should be getting, full dose hormone therapy after their BSO. Then there's that question about like, well, after they've had their BSO, like if you have a patient who like maybe had cancer at 25, breast cancer, right? And then they're supposed to get their BSO at 35 or 40. What do we do about their hormone? I mean, you could argue that for the preceding 15 years, they were getting estrogen, right? And it's like, so now we're just going to take it away, not replete it. So I do think there is like a good discussion, especially if they've been cancer free for a period of time, but that's where it's tough, right? If they're a BRCA patient who had breast cancer, but yeah, I mean, I think shared discussion, Duave might be a consideration in those patients. And then I also think like, do they have breasts, right? If they have no breasts, then I'm also less concerned.
Very good. Okay. Thank you. It was a great talk.
What do? You said, I know what I do.
I'm sorry. Well, no, we get, when I see, and I saw MSK patients, so I use they put Mirena in, and then give them low dose patch, estrogen. And I use a lot more of the of transdermal estrogen only because of, I think if it bypasses the liver, I think it's been shown if it bypasses the liver, although they keep talking about DVTs and estrogen. If it bypasses the liver, it really shouldn't cause an increase in DVT because it's not affecting it shouldn't be affecting the clotting proteins. So clotting factors. So that's what I do.
Yes, for non-cancer patients. Yes, I love the Mirena. I love the Femrene, non-oral. Yes, I agree.
I see that Dr. Pratenkar has her hand up with just 3 minutes left.
Thank you so much for this phenomenal talk. It was really amazing how you explained complex concepts and made them really clinically relevant. Just a quick question, as you mentioned, many GYNs, even GYN oncologists, we feel unprepared to address sexual pain in our patients and, including breast cancer survivors. And from your experience, what are practical steps we can take in residency training to improve our comfort and competence in managing these concerns?
Well, I think you're doing it. I mean, that's my goal is right to get the word out and spread that this is safe and we should address it. I also try and do like a talk with my hemonc fellows at my institution, like once a year, just so that they're not like shocked if a patient comes and they're on vaginal estrogen. So I think the more comfortable we are about incorporating this into our curriculum and talking about it, I think is helpful. And I feel like in my years of giving board exams, I've even seen more and more people having that on their case list, like a breast cancer on estrogen, right? So I do think it's evolved somewhat.
With just 2 minutes left, I see Dr. Gerda has her hand up.
Thank you. I just wanted to address Dr. Siegel's questions about BRCA patients who underwent BSO but still have not had a mastectomy. There's real concern about using hormonal replacement therapy in those patients who still have breast tissue and have 70 to 80% chance of having breast cancer. And of course, it depends on the BRCA1 or 2, but I know my medical oncology colleagues have a lot of reservations about using hormonal replacement therapy. And so I agree, after mastectomy, I think we would feel a lot more comfortable with the safety profile.
Yeah, but I even think like if you have an 80% chance risk of breast cancer, taking hormone therapy and increasing your risk by 0.05% is like a drop in the hat. I don't think it's clinically significant. And so I feel like quality of life wins in that. So that's what I usually talk to my hemoncs about is like, I think at that point, what is that additional risk is so minuscule that, and if it helps them to like exercise, not have a sedentary lifestyle, lose weight because they're happier, like I think that's a overall probably benefit. I don't know. That's how I talk to my hemoncs. I think if you compare 80% versus not, it's like not clinically relevant at that point.
I mean, weren't they on birth control prior to the onset of taking out their ovaries? Before they took out their ovaries, right? So aren't they on much higher doses of estrogen for the last 10 years prior? That's why I was thinking I put them like even on 0.025 patch or 0.037 estradiol patch. It's so low comparatively to what they were taking prior with the OCPs. So just to get them normal function, that's what I was.
All right. Well, I think I'm going to have to wrap it up. But this has been such a great, Dr. Kaiser, thank you so much.
Thank you so much for having me.
We very much appreciated your talk this morning. All right, but we do have to end it there because there's a rule that I have to stop on time. So I'm just going to wish everyone a safe and successful day. Thank you.